Hello, hello, everyone. How are you doing today? Today is a beautiful Wednesday. I think it's Wednesday for everybody everywhere for sure. Because even in a lot of times we get international folks, Michael, and so sometimes it's late for them, but it's still Wednesday. So happy Wednesday, everybody. So welcome. My name's Chris Tronson. Liz McInville will be here any second. So Liz will pop up, the better looking half, I always tell people. So she'll be here pretty soon. But Liz and I every Wednesday run either an Ask the Experts or a Lunch and Learn. And really, what the goal is, we all know that many of you right now are struggling and looking for resources, looking for education, and looking for community. And that's really what these live streams are for. So Liz and I are both licensed clinicians in our respective states, California for me, Texas for her. And we want to provide you with feedback, education, resources, direction, and then, of course, community. So if you're here joining us, make sure to put whatever social media platform you're on. You can go into the comment section and say hi, introduce yourself, where are you from? Maybe you could talk about what subtype you have or share any or as little information as you'd like. A lot of times we'll see in the comments people giving each other support back and forth, and sometimes finding people that have similar OCD or related disorders, as well as similar location. So definitely put in the chat. Let us know where you're at. And let's get started. So Liz will be here any moment. Before I introduce my guest, who I'm really excited about having, just a couple quick announcements. Always remember that these live streams are educational and not intended to replace therapy. So for treatment-related questions, please work with your provider or contact a local clinician. You can always use the IOCDF's online resource directory at iocdf.org/find-help to locate a trained clinician near you. The International OCD Foundation is not a crisis hotline. If you are in a crisis or you are ever feeling suicidal or unsafe, please call the 988 Suicidal and Crisis Lifeline by dialing 988 or 988lifeline.org. Go to your local emergency room or call 911. And then lastly, we want to create a safe space and be kind and respectful to everyone. At the end of the day, we're all here to support one another. Also, a note that this is being broadcast on several social media platforms and being recorded. And that's a good reminder. If you really enjoyed this and you think somebody else in your life would definitely benefit from watching this, you can always direct them to the IOCDF's YouTube channel, youtube.com/IOCDF, and that way you can watch all of these back as well. I was just about to introduce our guest in the title, but Liz, why don't you introduce yourself? I let them know you're on your way.
Hi guys, sorry we've all had patient mornings that are busy. So
Same.
you guys, so excited to be here. Michael, we're so excited for today. Chris was just bragging for the past 2 weeks about how your live streams garner so much interest and excitement. And so we're really excited to be able to talk about this topic, why it's important to us, and yeah, just get going. But I'm going to let Chris take the lead on the introductions because he's really excited and has a lot of thoughts around his goals for today.
Yeah, so where I first saw Michael at the online conference, I wasn't able to see the actual presentation on inhibitory learning, but I did catch the Q&A and saw Michael answer the questions. And I think for me, inhibitory learning was such a game changer for me. I obviously was, when I was in my own treatment, was only taught the habituation model, and then always thought that that's how I was getting better. But when I really learned about inhibitory learning, I learned through a paper John Abramowitz had put out and wrote it about in my thesis, started to change the way I saw my own OCD, how I approached exposures and treatment, and then as a clinician. So I'm going to have Michael talk about, but I do want to introduce him. We have his official bio, so I want to shout it out. So Michael Wheaton is an assistant professor of psychology. He joined Bernard's faculty in 2017. Prior coming to Bernard, Dr. Wheaton was a postdoctoral clinical researcher in the anxiety disorders clinic at the New York State Psychiatric Institute, and he previously taught at Yeshiva University. His research interests focused on the psychopathology and treatment of obsessive compulsive disorder and related disorders, with a particular emphasis on behavioral therapy. He's a licensed psychologist in New York State and teaches classes in abnormal psych and clinical psychology at Bernard. So excited to have you. So maybe we'll jump right in, Michael. So what is inhibitory learning, and why is it important for everybody who's watching, clinicians, people with OCD? Why should they know it, and why can it be helpful in their own recovery?
Sure, yeah, happy to talk about it. So inhibitory learning is sort of an approach to understanding how exposure-based therapies work. And it is coming out of the research literature, largely led, as you mentioned, by John Abramowitz, who I just also should shout out because he was my graduate school mentor, and it was an amazing mentor and teacher, and has done a lot of work in this area. And then Michelle Krask from UCLA has done a lot of work in this area. But it's sort of an understanding of like, well, we know exposure-based therapies help with anxiety, and exposure and ritual prevention is the behavioral treatment of choice for OCD. But trying to understand like what makes exposures effective and the mechanism by which they're working. And sort of the classical EPT, emotional processing theory of how exposures worked prior to inhibitory learning was going based on sort of an extinction or habituation model of you acquire a fear and then we extinguish the fear by repeated confrontations with it. And inhibitory learning is a little bit different, which suggests that like, okay, so maybe instead of just simple extinction of like erasing a fear memory, actually it's more complicated than that. What we are thinking is happening during an exposure is that we're sort of developing a new memory that's happening during the exposure session of previously, if we're afraid of something, we've developed some sort of a fear-based or a threat-based association with that thing, whatever we're afraid of. And inhibitory learning would suggest, well, now when we do an exposure and nothing bad is happening, we're facing a fear and we're persisting and we're seeing that like we're okay, we're developing a new memory, a non-threat memory. And now we sort of have two memories. We have our threat association with the feared stimulus, and we have our non-threat association or safety memory. And it's that both memories are embedded in your brain somewhere, and then they kind of compete to see which one is going to be expressed. And the idea is inhibitory learning means that our non-threat association, the new memory that we made, is going to inhibit the fear from being expressed, because we will have this new safety learning that, okay, maybe our feared outcome is unlikely to materialize. And so it suggests that we might tweak. We're still going to do exposure therapy. We're still going to face our fears, but we might try to do it in ways to enhance the new memory that we're making so that it will inhibit the expression of the fear memory.
I don't know if you both feel this way. I think the reason also in what I've learned, especially I work with a lot of like teens and young adults, I find inhibitory learning lends itself really well with acceptance and commitment therapy with ERP, in the sense that those new memories that I'm trying to get my clients to learn, I also like to associate it with things that they enjoy. So for instance, if somebody really struggles with eating without washing their hands, and I find out they like chocolate, and I buy a mall and there's literally 2C's chocolate candy stores, and we'll go over there and we'll do exposures with chocolate, something they enjoy. And so they're learning, obviously, that their old fear, like you were saying, about eating food without washing their hands first is dangerous, right? They're replacing that and seeing that that's not dangerous anymore and they can do it. And they're associating it with something they enjoy, a value. They're at a mall, they're out around people, etc. So I've just seen it be such a game changer. Have you gotten feedback from other clinicians as well? And maybe Liz can give examples, but have you heard from other clinicians that people are really like, clients are really comprehending inhibitory learning and it's making sense for them?
Yeah, I think I absolutely, in that like exposure you described, we would kind of put it in the category of it's a really good one because it will stand out in your mind. It's like we're doing an exposure. We want it to be memorable. We want to like remember what we're learning today, and having it, you know, you could do it just in the office where you bring in the piece of chocolate and the client eats without washing his or her hands. But if you do it in the mall where it's much more like a visceral experience and there's more stimulation, like that's going to be a vivid memory. And maybe that's what will help, is like we want to remember this day that we did the exposure and have this top of mind so that this memory stands out to us and not like some earlier memory that like instilled the fear. So I think, yes, I think making it vivid, making it novel, making it memorable is something clients can connect with, because it's, you know, it's makes therapy even like a little bit more fun and engaging. I don't know, Liz, do you want to say something?
I could eat chocolate too, so.
Yeah, exactly. Yeah, you know, I think that one thing I find really interesting that I wanted to chat a little bit about today is that I feel like the way we as clinicians hear about and think about inhibitory learning, it just makes intuitively a ton of sense to me, right? So when you think about OCD and you think about anxiety, the thing I'm always telling our patients is what I yes, the exposures are important. Yes, when you come here, you're saying I run a residential program. So right when you come to our clinic, you're saying, okay, Liz, these are the 10 things that if I address like my OCD while I'm here, like I'd feel good about, that would make me say treatment successful. And my answer is always something along the lines of like, sounds great. Like we will address those. That's the plan for sure. And you should see those go down. But actually addressing those things isn't really what's that important. What's more important is, what did you learn? Right? It is much more important for me to know that you understand how to change your relationship with anxiety and OCD, that you understand the ways that you sometimes intentionally, sometimes unintentionally give your anxiety and OCD power or feed it, than it is for me to say, oh, we reduced these 10 symptoms, right? And so I say that just because sometimes when patients come here who've had a lot of ERP in the background, my goodness, in their past, they have this really clear habituation model that for them, it's like, hey, I want to jump in. I want to do ERP. I want to like make it where I'm not afraid of these things. And our answer is like, that's awesome. And can we actually slow down? And can we do it a little bit different? And inhibitory learning, to me, has allowed us to approach ERP in such a different way, because it is in a thoughtful, slower way where we're allowing space. A quick example, but a lot of people from other programs will always say things like, oh, well, how do you measure SUDS before and after, subjective units of distress scale? So a lot of people will say anxiety level on a scale 0 to 10, some use 0 to 100, and they'll say, what's your anxiety before, what's in the middle, what's after? We canned that recently. We don't ask patients that at all anymore. And one of the people recently I was talking to, they're like, why aren't y'all asking that? I'm confused. And I was like, because if we ask that, we are re-emphasizing that your anxiety is what matters. That we're trying to tell you, hey, actually, like, you can feel anxious and do hard things. Anxiety isn't what pressure shouldn't be on anxiety. And while anxiety goes, if anxiety is high or low, and if it's gone, the actual learning is about, did you learn something new? Were you able to have an experience? Were you able to have anxiety and still love that chocolate? Or, is that the memory that's more ingrained than I felt anxious or that was scary? And so I say that just because for both clinicians and patients listening, I want you to be really thoughtful about, as you are using this model and you're thinking about, what did I learn? What am I learning? What has this new experience taught me? What new memory has it formed? I want you to think about, is there some kind of older school habituation model stuff that I might still do that sometimes reinforces the opposite, right? We'll have patients that come to us from other programs and they're like, oh no, I just did an exposure, I can't get up. And we're like, what do you mean you can't? What do you mean you can't get up? Like, we gotta go do stuff. And they're like, oh, I have to sit here and wait till my anxiety drops. And I'm like, well, we don't do that. And they're like, well, why don't you do that? And I'm like, because that message is that anxiety is dangerous and that you can't move on until you don't feel anxious, and you just have to sit and wait to habituate. My answer is like, habituation will probably happen. That's awesome. But that's not what we're putting the importance and the weight on. So I would just love for you, sorry, I just rambled, but I get so passionate about this, but I would love for you to talk a little bit about just how this model has actually changed ERP for you in practice. Like, what are some things you do different than maybe you would have done had you been trained in a habituation model, or that you used to do previously?
Yeah, no, I think those are great thoughts, Liz. And like, I really resonate with the one of the first things you said about how maybe sometimes, as with the older model, people may be focused on particular content of like, well, these are my top 5 like thoughts that I need to habituate to. And they'll come in with like a list of like, I want to no longer have my fear reaction to these particular thoughts. And of course, I mean, that's a worthy goal and we still want to do it in therapy. But what I think you're getting at, and what I've taken away from an inhibitory learning approach, is it's not only about the content, it's also about the process. So if we distinguish between like, well, these are the particular thoughts that we want to decrease our reaction to, that's the content. But really, like, the approach to doing the therapy that I think is really new and like interesting is focusing more on the process of like, what does it mean that I had this set of expectations for it, and then I used an exposure as a way to test those expectations or even violate those expectations, and then I can learn a more like generalizable lesson, not just like, oh, this particular thought, I don't need to be afraid of it, but maybe, oh, okay, like maybe it's going to be other thoughts too. Maybe it's like I'm learning about myself that I can have this type of thought or like this situation. And I don't have to necessarily do an exposure to every single situation. If I learn like, oh, this is the type of situation that I'm likely to have an extreme reaction to that's not warranted. And then it becomes more the process of learning to like kind of use exposures as a tool to like learn something new of like, well, my mind is telling me don't do this, but if I take that as what's my expectation and then give myself the opportunity to violate my expectation, I might learn something new.
Totally. And, you know, it's like, how are we reinforcing that across the board? And what I'll say is for trainees and clinicians, I do think a habituation model is a bit easier, right? It's a little bit easier for you to be like, okay, the way I treat OCD is I identify all the things you're afraid of and we go tackle it one by one. And when you feel better about it, you move on. It's like, yeah, like that actually is easier to do than to truly understand why we want you to do it, to understand the messages you're sending each other to yourself, to truly understand how anxiety and OCD works as a whole. You know, I used to call it, I remember sitting with a patient and I was like, so do you want to do a fear extinction model? And they were like, well, no. And I was like, why not? And it's like, because that's what I've always done. And I've been playing a game of whack-a-mole with my OCD for 20 years because I know that if I sit here and do this, like I always call it like standard ERP, but if I sit and do the standard ERP, I can no longer be afraid of that one doorknob or that one trash can or that one bathroom, but it feels continuous. And with OCD, it throws more and more at you and you're constantly having to do it for all these different things and it feels never ending. But inhibitory learning has allowed us to present a concept in which you're still going to no longer be afraid of the things that trigger you, but it actually sticks, right? It doesn't give OCD a chance for things to shift as much. Not saying OCD won't try to throw new things at you, but you have the tools to be able to quickly understand, oh man, I see what's happening here. Like it gives you that kind of bird's eye view versus like, I'm responding to a specific trigger. It's like, no, I'm responding to my OCD. I'm responding to my anxiety.
Yeah. So like looking for a lesson that's generalizable, that like, oh, I did this particular practice today, but I can learn from that practice in a way that extends beyond just that practice.
Exactly.
Yeah, absolutely.
And the last thing I'll say, Chris, I know, sorry, but I love this.
No, it's okay.
You know, so our we do 4 hours of active ERP a day in our residential setting, you know, in addition to 2 groups, which is pretty standard for most programs. And in the past, so it's a morning block and a PM block. And in the past, we would do at check-in and check-out. At check-in, we would say, what exposures are you going to do? What's your anxiety level? And then at checkout, it would be, what exposures did you do? And what's your anxiety level? And we would say, write down on the board how like the highest level your anxiety got to. And we would say, oh, look how great it changed. And now our questions are, what's your plan for the exposure period? And how are you going to engage in response prevention? And then our checkout questions are, what exposures did you complete? What urges came up and what did you do? Mm-hmm. What are you learning or practicing? And do you have questions or need support? And again, it's just such a different model of it's less about this, like, I don't know what to call it, but manualized approach of like boom, 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 and much more of like, can we slow down? Can we process what happened? Can we acknowledge what you just did and why it felt different and what you did that was different than in the past, right? And I just think I'm telling y'all this just because I think a lot of people, you guys, think that ERP treatment means this like manualized, standardized approach. And I actually believe inhibitory learning really is what started to, in my opinion, break a lot of the way for these more ACT and values-based approaches because it all aligns much better, right? Like that aligns very clearly with an inhibitory learning model of like, what are you learning? What new memories are you having? What experiences are happening versus did you habituate? Do you feel better? Let's move on to the next exposure.
Yeah. No, and I would just say, so I think like the traditional way with a hierarchy, logical progression does still work, right?
Totally,
it still is
totally.
a good approach. It's just maybe we're deepening, we're expanding beyond. And like you're saying, there's actually some data that John has, the Michelle Krask have, that like adding variability, so it's not so formal of like, well, we just come in and punch this ticket and we punch that ticket and we're just going in a logical order, which is effective, but we can make it even more effective by having variability to the hierarchy. And, people are, instead of like having the hierarchy be a list that goes in order, having it on paper, cutting it into strips and putting them in a fishbowl, and then you pick, what am I going to do for my exposure? And you pick it. So there's like some unpredictability, and that is thought to, whatever we're facing, we're a little bit surprised by, and then we're going to remember it better because it was a new experience and it wasn't quite so predictable.
And we can't say, I'm not ready for it yet. It's like, no, we're doing anything that pops up, right? We're not sending those messages. But I want to say what you said, Michael, I think is so important, you guys, is that standard model is what saved my life. I want to be very clear about that. That just because I think sometimes people hear this and they're like, so I've been doing the wrong thing the whole time. And like, this isn't, it's like, whoa, like, I'm not saying it doesn't work. It definitely works. It literally changed and saved my life. And this new model has helped me have an even better understanding and has taken me to a deeper level of recovery and freedom that I didn't think was possible based on that kind of more standard model.
Yeah, absolutely. I think that was really good. Well put, Liz, and good to say, because we're not criticizing the traditional approach and we're not criticizing any of the researchers who developed the traditional approach. Like, they're still sort of using the principles, but we're just maybe making it even better. And yeah, so it's not to say that you can't do it that way. It's like, okay, well, we could also add to it or deepen it.
Yeah, something I think of as you were both talking about, like how you can still use the old model. I think of it as like our parents, right? They drove cars and they were still really effective. Now cars have, backup cameras, and it has like a light that comes up if it's not safe in your blind spot. It doesn't mean like the cars didn't work of the past. It just means like we've enhanced cars and now they're safer and they're more effective. Just for clarity real quick, Michael, so if somebody's watching this, is it something where the habituation model and inhibitory learning, like they can both work? Are we throwing something out? Just for clarity, because I know if I was watching this, I have OCD, so I'd be all particular with what y'all saying.
Sure, yeah.
Where both can happen simultaneously? Like, maybe go into that a little bit.
Yeah, I mean, it's almost like you could do the same exposure trial. It's really, what is the emphasis? And I think Liz is putting it well, that maybe the old style would be to emphasize, what's your SUDS rating? Like, what's your fear rating? What's your fear thermometer? Like, very much focused on the body's physiology to see, is your physiological reaction coming down? Are you habituating? And like, that habituation can be happening during the same exposure trial, but an inhibitory learning approach just would take that information in, but not set that as the goal or the bar to say like, well, if you didn't habituate, it was a bad exposure. Because, sometimes our physiology may not habituate, but we can still learn a lot and we can still have a great exposure, even if, maybe we're still having a heart racing, but we learn that doesn't mean we are having a heart attack. That doesn't mean we have to stop. Like, you could still do valuable learning. So it's really like the same behavior, the same thing could be happening. It's what you're emphasizing and how you're thinking about it.
Yeah, no, I agree. I mean, one of the things like Liz does, the same thing for me, what's changed, I think a big part of my treatment for my clients is after the exposures. Like, if we go to the mall and do the Seas Candy and come back, I like to talk about like, what did you learn? And then kind of what you were talking about, Michael, is like, how can you make that learning universal? So that way we don't have to go to every freaking store in the area. I mean, every snack place in the area and grab food. What did you learn about eating food without washing your hands, et cetera, so that they can then apply that and we don't have to go to every single thing and tick it off. It's like, oh, I'm pretty confident now after a few times of doing it that I could go to pretty much any food place, not wash my hands before, and I'll be able to manage my anxiety. I'll handle it and do better. And then I always think about like, how can you, how will this exposure enhance your whole life? And for me, ever since getting involved in understanding inhibitory learning, it's gotten me out of the office more, trying to put them in situations to create new memories that are exciting, that are vivid, that kind of almost like highlight and replace the old memory that they had maybe 3 years ago that initially triggered the fear response. So, how can you enhance this in your real life? What are places you want to go during the week to go eat and try food? Who can you bring with you? What kind of conversations? And then people will come back and they're like, I have so many fun memories now of eating food versus like my whole, thoughts when I go out to eat is like, what am I going to touch? What do I have to wash, et cetera? So that's, just like y'all are talking about. It's like enhanced treatment.
And I also want to say is that I don't want us to send the message that every time you go do these exposures, it's going to be a great new memory, right? Sometimes it doesn't go as well. Sometimes it isn't what you wanted. And that's actually just as important to debrief. Like my thing with my patients when it didn't go well, and they're like, I'm like, what'd you learn? And they're like, that I give OCD an inch at once a mile. And and that's just as important. Like it is just as important for us to debrief what you learn and what you don't learn.
Yeah. For sure. Sometimes exposure is not working out the way that I had planned it. For instance, like I have a client that in the past where they had to apologize a lot. They always thought they're hurting someone's feelings. And because of their anxiety, the way something came out when talking to a worker was a little bit like curt and rude and short. And the worker kind of got offended. And the client was like, oh no, the exposure went wrong. I'm like, no, the exposure went right. You're afraid of triggering people or making people upset. The worker got a little bit upset, but you apologized. We got through it. And you learned that you could handle if there is somebody who's slightly upset at you. So sometimes we don't need the exposure to go right or wrong. That's not the goal. It's to really learn, going back to the learning, that you can handle any situation thrown at you. And I think one of the emphases too that I've been putting with clients since learning inhibitory learning is that the learning is not just about the thing you're doing. It's about yourself, and it's about how you handle scary situations. So you're teaching yourself and you're proving to yourself like, hey, I don't need to be so afraid, because if situations are tough or do go wrong, I can handle it. And I love your fishbowl idea because it teaches the person, like, you don't always need to know what's happening before you do it. Unpredictability sometimes can be absolutely an asset, and being able to kind of be flexible in situations is teaching that person like, look, I can handle it. I can trust that I have the ability to land on my feet no matter what happens in front of me.
Yeah, absolutely. Like in the research literature, they call this occasionally reinforced extinction, that from time to time, while you're facing the fear that like an aversive stimulus happens, actually you learn better. Like so things just like that, like, well, that didn't go perfectly smoothly, but we can still take away from that because life doesn't go perfectly smoothly. And like maybe that, especially, it's really at the end when we're processing the exposures, that's where I think people maybe would benefit from support to like internalize a message of self-efficacy, and not like, like, because you could in your mind make it that a bad outcome happened when it was a survivable outcome, or it was like not as bad as maybe predicted. But that's where I think we do a lot of our work, is processing exposures to look for.
So could you break that down for us, Michael?
Yeah.
Of like, maybe I think some of our viewers tend to love specific examples, but like, let's give an example of like contamination, and we're going to go out and use a public bathroom for exposure. And maybe you could give an example of like what the old school model might look like, of like what would be a non-inhibitory learning model, but that still works, versus the difference of inhibitory learning.
Yeah, sure. So I think partly it might be the beginning of the exposure. Like, what did you select for the exposure that day based on like some element of like randomness? Like, okay, we weren't sure which bathroom we were going to go to, but we like turned it into a game. We knew we were going to go to the mall and use the bathroom, but like there's many different bathrooms in the mall. So we like.
So gamify
it. So we're going to be surprised which bathroom we use. And then I think another element would be to not just focus on getting through it and monitoring our like SUDS level, but more like saying, okay, what do I want to like learn today? What are my expectations? What am I afraid will happen? And then I'm going to treat the exposure as an opportunity to violate those expectancies. I'm trying to think of like, I can think of a really good example of something happened that we didn't anticipate happening, but it stood out in our minds as something that was really novel. And we stuck with the exposure, and it went really well. I had a client I was working with who was afraid of contamination, and we went into the subway. And I'm here in New York City, so we have the subway, and many people are afraid of the subway because it is a little bit dingy down there, right? So the exposure was going to be riding the subway, actually sitting in the chairs, not just, sometimes people will kind of stand in the subway and use their elbow so they don't have to grab the subway pole. So we said, our expectation is we're going to sit in the seat no matter what. And what we found out was surprising was the train was in the station, but we're at the very first station in the line. So the train was actually being cleaned. And there was a guy cleaning the subway car. He had a dustpan and a broom, and he was sort of sweeping things up off the floor. And then there was a chair where someone had left like a bag of chips or something. And what he did was with the same broom that had just been wiping the floor of the subway, just swept the bag of chips into his dustpan, touching the seat that a person is going to sit in with that same broom. And so the client I was with was really surprised. Oh, that's how they clean the chairs? Like, this is what happened? And so we were like, well, this is a new thing we didn't expect to happen. But what do you think? Like, are other people going to sit in that chair? Because they didn't just see this happen, but we can now assume this has happened in every single chair in the subway car. So what's our expectation if we sit on the seat? And let's see if we can do it. And that, I think, focusing on what the unexpected and seeing it as, well, but this was an opportunity to learn something new. And we learned about subway maintenance, and then we actually did it. And it went well. And, you know, it was maybe more anxiety than we were anticipating, but because we weren't necessarily, we didn't necessarily know what we were going to get. So if we had said, well, today we're at a 5 out of our 10 position hierarchy, and so we're ready for about a 50 or a 60 on our severity. And so, oh, well, that's harder than I was anticipating. I'm not ready for it yet. We'll do that next week. You know, that's maybe something that could happen with the traditional approach of proceeding logically, but proceeding from a stance of like, well, we want some novelty and we want to be surprised, and surprise, look at that. And, you know, of course, it was up to the client whether she was going to be willing to do this, but we reinforced her for being willing to try it, and she sat in that seat. And then it turned out to go great. So I think that's probably a good example of the difference between like, okay, we're ready for this level of anxiety, let's get something of that exact level of anxiety, versus let's go have an experience. We'll like try to surprise ourselves. We'll try to learn something new.
I love it. This is so helpful. And I'm just looking at time because we have started to promise viewers that we'll make sure about halfway through we hop into questions, and a lot of these are super relatable. So we'll start there. So the first question, so many people are saying hi, and this has been so great. So I love that. One person, Amy, said that inhibitory learning intertwined with habituation, ERP, ACT, and DBT has worked for her. Inhibitory learning was like turning the light bulb on for response prevention. So I love that.
Oh, good.
And then some folks saying they're going to research your articles and watch them, and they just love it. So we'll take the first question, Brendan, from Andrew at 12:13 your time. It says, can you explain inhibitory learning versus habituation from a scientific perspective? We've explained it in other terms, so let's just kind of share the science.
Sure. So it's the idea that there's a memory trace inside your mind that's either the threat-based association of the stimulus, like the things that we're encountering with OCD, that we have to learn to be afraid of them. And so something has made an association of this is germy, and if I touch it, I'll get sick, or this is dangerous, and if I go there, something bad will happen. Like, we learned this association. So it's sort of a paired association that's in a memory trace. Extinction learning or habituation would be saying like, okay, well, if we just face the conditioned stimulus, the CS, over and over and over again, that will gradually decline in strength and then be extinguished. Inhibitory learning would suggest actually maybe the conditioned stimulus still retains the association with threat, but we're learning a new memory, a safety memory of a no threat association of I can eat the C's candy and actually enjoy it and not get sick, even though my hands were dirty. And inhibitory learning would suggest that memory trace of safety inhibits the expression of the fear memory. And that's what we're trying to do. We're trying to make strong safety memories, or strong inhibitory memories, or strong non-threat association memories in our exposure trials. We're still doing exposure trials.
The reason I love it so much is I feel like it relates to how we learn, right? Like, all of us on this panel right now, we're afraid of something at one time that we're not afraid of now, right? I mean, I think there is a relationship with dogs. I had a dog snip at me when I was a kid, and I used to be afraid of dogs, and our family just kind of went with it, and we only had cats forever, right? It happened when I was at my dad's house, and we only had cats over there forever. And I remember one time asking, like, when are we going to get a dog, when I was in high school? And my dad was like, oh, I thought you were afraid of dogs. I was like, Dad, that was like 6. Like, I had learned that dogs all don't bite me. At 6, I didn't. And from like 6 to 10, I was like not around dogs. But I learned, like, I started to have good memories. I go to friends' houses, they'd have dogs, they're sweet. And my brain almost like expanded. Okay, all dogs aren't scary. Some are, but some are great. And in fact, the majority of the ones I'm around are great. So that works in non-OCD related things. So to me, when reading upon this, I'm like, that's kind of how we learn as kids to not be afraid of the dark. We have new memories where the dark is great,
Yeah.
And I love
exactly.
the memory trace idea. It like reminds me of this, like, okay, we have this associated belief that's just ingrained, and every time we avoid or do a compulsion, it further ingrains it in the railroad track. But like, actually, we can disrupt it and like take a new path and have a new memory trace that exists. I love that explanation.
Sure. So it's not only about extinguishing an association, it's about learning something new. And really, exposure trial says experiential learning. Let's go learn something by having an experience.
I think also it's the easier way to frame it, right? So if I go to a client, I'm like, let's go touch something multiple times so that you can get used to being not as anxious touching that thing over and over. Sometimes people are like, ugh. But if it's presented in the way that you just talked about, like, let's go learn. I always tell my clients, like, we all do have a superhero power, which is flexibility and being able to like land on our feet and be spontaneous. I'm like, let's go to the mall, or let's go to the park, let's go to the beach, like, let's go learn something today. Let's go teach our brain that things aren't scary. And I think the overall message that clients are getting is like, I can handle this, because I think that's the message they get with inhibitory learning is I can handle this. I can handle spontaneous things. I can go have fun. Like, everything doesn't have to be doom or gloom. And I think with inhibitory learning and ACT, I think those two really helped make ERP this less scary doom and gloom, and more so like, let's go out and like gain your life back and learn new memories.
Totally.
Absolutely.
I love it. So many people are saying great things and just talking about this. And then Chris, to respond to one of your examples, someone said, my son's therapist took him to the mall for big exposures, and we as his parents were just blown away by the progress that it started for his OCD. So I love that. Inhibitory learning has supercharged recovery for a lot of my clients. Love this so much. So many funny questions too, and different things. But people are saying, Michael, they loved you on your anxiety toolkit and loved that talk you gave on it there. Let's go to 1221 from Josh. Have you found that there's space for integrating the habituation and inhibitory models? Some of my patients have worked on trusting themselves to habituate to their triggers and intrusive thoughts. And I wonder if they've learned a thought process that competes with the beliefs that their anxiety is unbearable and will last forever. Like, do the models go in tandem sometimes and work together?
Yeah, I think so. I mean, this is great. Like, what we're talking about in the future is going to be a personalized medicine approach that is not going to be a one size fits all. And maybe certain people will resonate with the different elements of it. But this idea, I think, like, inhibitory learning, just as we're talking about, is it's learning. We're learning something new. But I think, like, the anxiety response that you have, that's still something you can learn about, like, during an exposure. That could be like a really big component of the learning of, like, I started out being really afraid of this, and actually as time went on, I'm less afraid of it. Like, that's something to learn, like learning about your own body's reaction. And that's usually when I encounter someone feeling really intense anxiety, we try to say, well, let's get just curious about what your body is doing. And we know anxiety can affect people in different ways, but it's still physiological arousal that's happening in your body based on an anxiety response. So let's not treat it with a threat association. Let's just be curious about that. Oh, my stomach is having butterflies, or, oh, I feel like these funny feelings of dissociation or depersonalization. But we can just learn about that too. Like, it's all what my supervisor would call grist for the mill. It's all stuff that we can process and learn from. And so, sure, some people, maybe the habituation is a part of their learning of, like, oh, my body's not responding the way it was at the beginning. But we say, oh, that's interesting. Let's learn something about that. What's that teaching you? What can you take away from it?
Yeah, I was gonna say, like, sometimes, like, I had a kid client. I have these mints in my office. I have, like, more, but obviously, like, my kid clients go in because my regular mints are, like, mint, and, like, the adults will take one, but these are, like, these orange flavored ones. I need to go buy some new ones because the kids go in. But, like, so for some of my kids, the habituation model just makes more sense. They're like, "Oh, it's not scary anymore." You know, they're just like, "I do it a bunch of times, and it's not hard anymore." And then
Well, and
habituatory learning is a little too hard, and I know it's happening anyways,
right,
but like
right,
they don't conceptualize it at like 7 or 8, as well as
yeah.
like, I do this and I'm not scared anymore because they play sports, right? And I'll be like, hey, when you played your first game, was it scary? And they're like, yes. And I'm like, now are you scared when you play? No, I'm not. I'm brave. And it's like, okay, well, let's go do this thing. It'll be scary at first, but it'll get easier over time. I know they're doing inhibitory learning, and I ask questions and think of it. But I think sometimes for younger kids, they just don't grasp as I don't think it's complex, but maybe to them, it's like it's happening anyways.
And
Yeah.
I think the thing to remember too is, first of all, I loved I like the discussion, the point. We should do a whole nother webinar on individualized approaches, right? And how when we talk about, often you guys are hearing us say ERP in a certain model because we're saying this is what the research shows works for the majority of people. But that doesn't mean that the way we approach it, the way we do it, or that we're for sure going to do this for every person, right? It's everything should be individualized, and we should think about what works best for us. And I will tell y'all, as a patient who's been receiving really good OCD treatment from multiple providers for 20 years now, I actually have customized my own approach that works best for me. Right. And sometimes when I'm really overwhelmed, I actually do things a little differently than when I'm really calm. And I can figure that out. And I know myself enough to say, this is what works right now. This is what won't work. And I've learned that, and I've been able to perfect that on my own. And so I love this concept because what you're talking about is that even when we're doing traditional habituation with a patient with ASD who, like, it's going to be less conceptual and more concrete and more behavioral, right? Or a child, inhibitory learning is actually still happening, but we're not necessarily using that terminology, and we're not really sitting down and saying, using the same language of what you learned. It's just like, oh my gosh, you did it, high five. That's still creating a new memory trace, right? Inhibitory learning is still happening, but from a conceptual stance, you may be explaining it or understanding it or recognizing it in such a different way.
And then I don't know if you both have this with some clients, they just don't care. They just don't care how it's working, right? I'm such a
Exactly.
nerd, and I love the clients that are like, I want to know what's going on in my brain, and like we're talking about it, and like, one thing I see different for people that really kind of embrace this idea of like learning, we're doing less exposures than a session and much more like processing and learning, and how can this, shift your lifestyle, right? Whereas with traditional habituation, it's more like, let's do some exposure back. And then sometimes they're just like, hey, it's working. I don't need to know why. I'm ready to like finish treatment and move on with my life. So I love how you were talking about this like individualized medicine approach, because I think sometimes Liz and I have talked about this, like people who were trained felt that ERP needed to be very manualized. There was no flexibility. It was very harsh. We did a talk at the conference with John Hirschfield, and one of the women in the audience who had a kid with OCD was saying, I'm a therapist. This approach just feels so cold. And Liz and I always get defensive because we're like, there's so much flexibility and there's so many ways to do it that is super effective, but you got to individualize it. Some people are going to respond to certain things much different than others will.
I'm taking notes because I love all of this, and I'm cognizant of our time. So let's keep going. This is great. Creating new memories. So many people have such great comments. So where did we end off at, Chris, if you had one? But let's go to Emily. She said, just joining, so I may have missed this. Where can I research more about the newer model to help educate myself and support my daughter in her ERP, which is sounding more like the standard? Is it called habituation? So this is actually called inhibitory learning. But Michael, if you want to give some good tips and resources for individuals to learn more outside of this talk.
Yeah, I think that some of the best resources are actually the research that is coming out of John Abramowitz's lab at the University of North Carolina at Chapel Hill. He and his graduate students are publishing frequently in this area, and he has given talks through IOCDF about this topic in the past. I don't know. Do you know, Chris, was that talk that he gave from the IOCDF online conference, is that archived in a way that people could get to it?
No, I mean, I think the IOCF kept it open, I think, for like 2 or 3 months for people to access, but it wasn't. I'm actually Googling right now to find the article that I used for my thesis back in but it was so impactful to put in the chat. But I mean, I know that if people go, what I love about these live streams, if you go to youtube.com/IOCDF, on, I believe, their research roundtable, John talked about his updated research on inhibitory learning. So I'll Google that too and put it in the chat for everybody.
Great. Yeah, and even though he writes academic papers in the peer-reviewed publications, a lot of his work is very accessible. Like, I think he gives really good examples. He also has like a popular press book, workbook for treating OCD, and I would imagine that some of the inhibitory learning approach made it into his workbook.
And I just put it in the back chat for Brennan to put in the chat.
And then I will say that this is a great opportunity for us to just plug our live stream. So during our live streams, one of the things we really always want to be
billing and payments are easy with simple practice.
Chris, you'll have to. One of the things, it's okay. One of the things we always want to be really cognizant of is like, what are we hearing and what do folks want? And then we use that for our future topics. And so for those who don't know, Dr. John Abramowitz and Kyle King do our research roundtable. It's on the second Wednesday of every month. And so I am going to send John a message and we will make sure he knows that I think it'd be really great for them to do a focused research update on inhibitory learning and articles and resources. And so I promise they would love to do that. And we'll make sure that we ask them to cover that during the next research roundtable. We had a question about a child who's 5 years old and treatment. And so I'll just kind of answer that one quickly. But what we know is that treatment for 5-year-olds is very successful. We can do ERP often as young as 4 or so. It can be really effective. A lot of it is based on obviously like the individual, the child's understanding of language, but then the way we are approaching it. And so many of us who do OCD work specialize in working with kids. So you'll want to find somebody who has some background in that, just because while the treatment's the same, the language is different, but there are amazing outcomes. And what I would say is if you feel like you're seeing your 5-year-old displaying symptoms of OCD, take them to a provider who specializes in OCD. I've never in my life heard somebody say, we sought treatment too soon, but every day I hear people say, I wish we would have gone sooner. So be preventative, take them to that provider. Good for you for being on top of it and being here. So many people are talking about how much they learned and how helpful this has been. As far as there's a medication question, Kayla, we will bring a psychiatrist on soon to be talking about medication. And then we have previous live streams, but any medication questions, just so y'all know, we do bookmark those is what you could say for our medication talks. But since we're not psychiatrists, it's important that we're not the ones covering this. Yeah, Sam.
I'm bookmarking that one right now to our psychiatrist list when we get a psychiatrist on. So I promise you, Kayla, that question will be answered when we get a psychiatrist on for sure.
Yeah, absolutely. So I just loved this. I feel like we learned so much, and Brendan has put some incredible resources for previous talks on inhibitory learning, previous talks that others have done, and you should definitely check that out because it was also like some of the recent articles from Dr. Abramowitz lab. So you'll see those and can click on those. So let's give some tips and tools to take home about the takeaways from today. So today we really got a chance to dive into inhibitory learning and talk about how it's a little bit different than what I would call of a standard ERP model, a more traditional habituation model. We also talked about how traditional models are still amazing and have a great place in this space, and that it's really about figuring out what your client needs and how you're going to learn and figuring out what that integration looks like. But Brennan, I would love if you could put up our top tips. I tried to write down the 4 things that I felt like Michael really helped me understand that differentiate inhibitory learning from some others. So number 1 is to gamify it. Think about a way that you can make this fun. You can do it a little bit different. And one of the examples is we always call it exposure bowl, but like putting your exposures into a bowl and then picking it randomly. And again, this is teaching you that you don't have to be prepared. You don't have to feel totally ready. We're just going to do it. We're going to have fun. Number 2, do not focus on surviving, but instead focus on learning, right? And this is, we've talked so much, you guys, about that white knuckling concept of like, we don't want you just white knuckling and doing an exposure. We want you to think about, what am I learning? How is this different? What does this look like? Did I still enjoy that chocolate, even though I was terrified to go do it? Number 3, set a plan before you go. and do this exposure on how you're going to fully engage. So what is it going to look like? And Michael gave a great example of being on the subway and, you know, setting the plan that like, yeah, we're not going to go and just stand. Like, what does engagement and not surviving look like? It's sitting, it's being, it's doing what other people do when they ride the subway in New York City. And then number 4, discuss the expectations that you have before you do it. And afterwards, identify what surprised you. So I thought I couldn't do this. I thought this would be terrifying. I thought this would be scary, but I was so surprised that I could still enjoy that chocolate and that I still got to taste it and that I desired more, or that I realized that wasn't my favorite. I don't really like that flavor and I wanted another one. What surprised you? Anything I missed, anything that you want to add from those takeaways? But I love having those because I need to see them and I'm a visual person.
Those were great. I mean, those were really, I think that gets like really to the heart of the matter with this approach, is to think of our exposures as experiential learning. Like, what can we go in? What do we expect? And usually those are threat-based expectations. But if we go in with a mindset of curiosity, of like, let's go have an experience and see what we can learn from it. I think that's a great way to like make it fun, make it engaging, and make it memorable. Like, we want to like remember what we did today, like especially if you're doing, you know, sometimes we're doing self-exposure as homework, but sometimes you're with the therapist and like you want to get a lot of bang for the buck of like, let's make a memorable experience today by making it like something we'll really remember, like the mall exposure that you were talking about. Like, that person's going to remember that experience. So yeah, so I think that will all make it generalizable. Like, okay, I remember that, and I can take away from that in a way that's not just going to help me with See's Candy. It's going to help me with all the malls, every store in the mall.
Or every time I feel like I can't do something, even, right? That goes back to Kim Quinlan. I love her quick little saying, right? You can do hard things. It's that we think we can't, and then we can do it. And guess what happens? We're proud of ourselves. I tell people, I give this example, and I would love to show this on a live stream soon, Chris, but I actually recorded my daughter because I wanted people to see in action how ERP works with kids who don't have OCD. But my daughter has this fear of this electronic dinosaur my nephew had. And the first couple times, even me being a behavioral therapist, I was like, oh, she's afraid of it. Get rid of it. Hide it. Like, you know, and then I was like, what am I doing? And I videoed, and it was so cute to watch her go from, I can't do it, Mom, I'm scared, to like, this is my best friend. Look how cute he is, and playing with him. Right. And like, if she could talk appropriately, right, I think she'd say like, I learned I don't have to be scared. And I learned that this dinosaur is still fun. Right. And she even said to me, which I thought was such a cute, like, this is inhibitory learning at its best. She was like, look, it has red lipstick, you know? And it's like, you're noticing the red lipstick versus the fact that you were terrified of this dinosaur. Like, how cool.
Yeah.
That was my nephew at Chuck E. Cheese. He was like terrified. And then as he finally got over it, Chucky comes out and does like a dance with the kids. And my nephew was like in the front, like dancing. And we're like, dude, like a year ago, Chucky was like, he loved Chucky and he was so excited, but he had to stay away from Chucky. And now he's like Chucky's bestie.
That's right. I love it. This has been, I'll let you guys wrap up, but Michael, thank you so much. And I hope we can have you on for 10 million more of these. And we will literally be like, I'm literally like, we need snippets from today. We need to be, because it's just, I feel like you do such an incredible job of helping us understand the research side, but like discussing it in a way that feels applicable. And I just loved those tips and tools that we were able to give where it can actually feel like, oh, I can do this. This feels feasible. So this has been incredible. I think that this has really changed the way that we can treat patients and the way that patients can understand treatment for themselves. So thank you for your work and thank you for today. And I will let y'all choose whatever important statements are to end with.
Michael, if I could go first, because I want to ask you to leave a final thought, and I'm going to ask you something. But I wanted to say real quick, because I was reading in the chat about the whack-a-mole. I think what is so good about inhibitory learning is, remember, we are learning the process. We're learning to trust our ability to handle things. I think your example of the subway was brilliant because it really just shows that there's going to be unpredictable things in an environment. And by learning, I think Liz, obviously in treatment, and myself in treatment too, like, we really trust ourselves. We trust that we can handle things. We know things are going to come up that we may not like, but we can handle it. Her daughter learned that, right? Like, I learned that I can handle the fear from the dinosaur. And so what I just hope people hear from today is like, this is a learning process. And when you learn kind of what's going on and to trust and the mechanics behind it, the whack-a-mole thing stops happening, right? It's like you're not so focused on I got to touch this doorknob. You're learning that I can go out in public and I can be around things and be okay. What I'd love for you to give us, Michael, as a final thought, and maybe kind of really quick to like 3 different audiences, but for individuals with OCD, for parents or family members, because we got a question, and then finally for clinicians, what are some things they could start today to maybe enhance their treatment if they haven't really been using inhibitory learning?
Yeah, I think, well, for the different audiences, well, first of all, thank you for having me. This was a great talk. But yeah, we really want to think of our exposure practices as a venue for new learning. And we want to be learning things in a way that we're open to an experience, we're curious, and we're ready to be surprised no matter what our threat-based expectations are. We want to use the exposure as a way to test them out in a way that focuses, there's a content of the exposure, sure, whatever we're facing that day, but also the process of like, here I am approaching something that makes me uncomfortable and learning self-efficacy, like learning the ability that like I can do hard things. There's a great way to put it, Liz, that I can, have part of me that gets sort of like frightened of this, but then also kind of push through or accept the feeling that I'm having and go towards it. So I think that is, if you're a clinician, that's maybe how to frame these exposures as experiential learning. What can we take away from it? We'll like process the exposure for lessons that can be learned about that exposure, but more beyond that, like generalizable. And maybe for family members of someone who's suffering and maybe needs a little bit of support to encounter those things, I think ways to help the person encounter it with a mindset of curiosity. And that was a great example you gave, Liz, about the dinosaur, of like that person who was frightened by the dinosaur at first, like starting to like learn more about it and notice new things about it, getting curious about, oh, it's actually got red lips. Like that's something I think we can encourage our friends and family members to get curious about it. Like, well, what else do you notice? Like, oh, that's interesting. How does the animatronic Chucky the Cheese work? Like, oh, where is this plugged in? Do you see where it's plugged in? And like encouraging a mindset of curiosity rather than just white knuckling it. Let's just get through this, so that really it can be a learning opportunity.
Thank you so much, Michael. Like Liz said, this was so great. I love Josh, who's a clinician in the chat, said like, now to go put this in practice, go team. I love that we inspired a clinician. Thank you so much, everyone, who came out. As always, Liz and I are absolutely honored to provide this space every Wednesday, and we couldn't do it without all of you. So make sure you are coming back every first, third, and fourth Wednesday of the month for Lunch and Learns and Ask the Experts with Liz, Dr. Liz McInvell, and myself. And then, of course, thank you, Michael, for coming out. We hope everybody found this valuable. Take care, and we'll see you back here next Wednesday at 9 a.m. on my coast and noon on the East. Take care, everyone.
Thank you.
Bye, guys.
Bye-bye.